Good evening. My name is Mary Villas, and I'm the president of PSC Partners Canada. And together with Ricky Safer, CEO and founder of PSC Partners Seeking a Cure, we welcome you to this webinar in the post-conference educational series, Embracing Diversity in PSC, the first in a series of DEI webinars. A very warm welcome to everybody and a sincere thank you to our moderators and panelists. Next slide. This webinar and the remaining educational series, part of the 2022 annual conference programming, have been made possible with the generous support from our sponsors, to the many community sponsors shown here who have been steadfast in supporting the work of PSC Partners. Thank you. Next slide. And another huge thank you to the 2022 annual conference corporate sponsors shown here: Gilead, Pliant, High Tide, Mirum, Escient, Perspectum, Chemomab, Children's Hospital Colorado, and the co-hosts of the 2022 annual conference, Brigham Health, Brigham and Women's, and Mass General Brigham. This project is supported by the Chan Zuckerberg Initiative. Next slide. Over to you, Ricky.
Okay. All right. So this just real quickly, these are three upcoming post-conference educational series webinars that we have rescheduled until early 2023. And I hope you will join us. So welcome everyone, and thank you so much for joining us tonight. We are really excited that today is the kickoff webinar, first in a series, as Mary said, to introduce PSC Partners' ongoing Diversity, Equity, and Inclusion Initiative. DEI is a concept that matters greatly to everyone in our PSC community. Tonight, you will hear individual perspectives from multi-stakeholders in this initiative: patients with PSC, caregivers, clinicians, researchers, and industry, all working together to identify and mitigate existing health inequities in the PSC community. Although PSC Partners has always embraced DEI in our culture, community, and governance, our active patient community still remains mostly white, English-speaking, and computer literate. We are counting on all of you to help us fill in these gaps. Tonight's program is only the beginning of our long journey to health equity for all patients living with PSC. We know that we have a lot of work to do, but together, with everyone's help, we will take the needed steps to provide optimal diagnosis, treatment, and clinical trial opportunities for all patients with PSC. After the panelists tonight have had a chance to speak, we will have a Q&A session. Now it is my pleasure to introduce our two wonderful moderators tonight, Dr. Kidist Yimam and Dr. Willie McKinney. Dr. Yimam, the head of our DEI working group, is medical director of the Autoimmune Liver Disease Program at California Pacific Medical Center. Dr. Willie McKinney is a highly respected PSC Partners board member. I'll turn it over to you now, Dr. McKinney.
Thank you. On behalf of Kidist and I, we want to thank PSC Partners for organizing this very important webinar discussion, and we're very grateful to be joined by excellent panelists. And it's my understanding that you're going to give us a brief presentation.
Yeah, I think I'm going to be briefly sharing few slides that we covered at our PSC Partners annual symposium or conference about DEI and PSC. You know, what do we know? What is known about healthcare inequalities in PSC? So I'm going to be briefly covering few concepts about healthcare inequalities in PSC. We know that data from other disciplines, such as from cancer research, have shown that patients that are minority, underrepresented, and disadvantaged have poor outcomes in multiple types of cancer. It's also important to know that when we are referring patients that are underserved, disadvantaged, or minority is not only patients of racial and ethnic minority groups. It actually includes a whole sort of categories in our society. So when we are referring to disadvantaged and underrepresented, we also have to think about, again, not only racial and ethnic minority groups, but individuals from another country or different ancestry, patients that have low socioeconomic status, patients that are disabled, patients that have limited or no health insurance coverage. It also includes patients living in a rural area where they have poor access to health care. It also includes our LGBT patient community, immigrants, as well as refugee, asylum seeking patients are also under that category. And we also have to remember that it includes our young or old patients as well. So it's not just Black or brown patients. It includes a whole category of patients that fall under that umbrella. So what do we know about healthcare disparities in patients with autoimmune liver diseases? As we know, autoimmune and cholestatic liver diseases such as PSC, they add additional problem because, for example, PSC is rare and difficult to diagnose, particularly in primary care setting. We don't understand it well. The cause and who's at risk is not well known. And also the natural history, meaning how is it affecting different type of patients, particularly in our diverse North America patient population, is not understood well. And there is limited or no approved medical therapy. For example, for PSC, we have no approved medical therapy, and access to specialized health centers and clinical trials is really the key, which is very difficult for our disadvantaged patients. I have heard it multiple times from some of my patients that are Black or brown, that they were told by other providers that they shouldn't be having PSC because they are not white. And this cross-sectional study really demonstrated that important lesson to all of us, that this was a cross-sectional study done by Dr. Goldberg, looking at the proportion of patients that are Black seen in 13 large liver centers in the US, as well as North America and Canada, really showed that the proportion of patients that are Black seen at these medical centers ranged from 0.7% of their overall PSC patients to 25% if we look at Henry Ford. And what seems to be very interesting here is that the proportion of Blacks that are seen at these clinics, the percentage seems to parallel with the percent Blacks living in that particular metropolitan area where these centers are located, making the point that, this data is not necessarily proving the point that or showing that PSC is as common in Blacks than whites, but it really shows that it's not a rare condition in Blacks. So Blacks are also affected by PSC. So we need more data showing or studying this type of findings in the near future. So how about clinical outcomes in patients with autoimmune liver diseases in general? Just one study. Again, there are limited studies, but a couple of studies I want to highlight here. One of them here published in 2021 in Journal of Transplantation. Among patients that received liver transplant in the U.S. from the year 1988 to 2019, African Americans with autoimmune liver diseases were more likely to be removed. Again, more likely to be removed once listed from the liver transplant list because of death or clinical deterioration, as we can see, compared to Caucasians. So this is a cumulative incidence of being removed from the liver transplant list seems to be higher here in African American compared to Caucasians. However, once they were listed, this particular study did not show any difference in terms of graft survival. There was one study that looked at outcomes of PSC patients that received liver transplant or that were listed for liver transplant, again, awaiting for liver transplant in the US from year 2005 to 2017. Of the patients that were listed, 4,046 were PSC patients. Among these patients, compared to non-Hispanic whites, the Hispanics had a significantly lower probability of receiving liver transplant once they were listed. And this study also shows that African Americans had a higher risk of post-transplant deaths compared to non-Hispanic whites. Just interesting data to look at from this study. For example, this was in 2021, the US Census data showed that the US population at that time was 18.5% Hispanic. But if you look at the proportion of patients that were listed for liver transplant, only 4% was Hispanic. So it makes you question if, Hispanics did not get as much chance to be listed. So we need to do more studies again to prove that. So when we think about promoting health equity in PSC, I think it's very important to differentiate between equality from equity. I keep on referring back to this image, which is so powerful that we borrowed from NORD, which is National Organization for Rare Liver Disorder. National Organization for Rare Disorders. They had this image on their website, which I thought was very powerful, really making the point or the distinction between equality and equity clear. So, for example, here, the first illustration shows that we have three guys of different heights. They are trying to watch a baseball game behind this fence. So if we give them the same height stepping stool for all of them, this guy is tall, this is the average height, and this guy is very short. So if we give them the same height stepping stool, we did not get everybody above the fence to watch the game. So this equal distribution of the same height standing stool did not help everyone. This guy did not even need it. This is too much. It's just about right for this average height guy. But the shorter guy, it's not enough for him to be above the fence to watch the game. But if we proportionally distribute the need for this height, the stepping stool height, meaning if we give this guy tall, he doesn't need the stepping stool, so he can just watch the game by himself, and just give one to this average height guy, he can watch the game perfectly fine, but give the shorter guy a bit more so that he can be up there with everybody watching the game. So this is equity. What would be very powerful is to get rid of the fence, like the barrier. If we can get rid of that, we don't even have to worry about supporting or giving them an additional resource to be able to watch the game, so that everybody, either short or tall, can just watch the game, no barrier in between them. So what is health equity? Health equity is different from equality, and it is a continuous commitment to meeting people where they are so that an optimal health can be achievable for all. So with that introduction, after we introduce the concept of health equality in PSC and PSC partners' dedication to work towards promoting health equity in PSC, we thought that the very next step would be having an open conversation with everyone involved in caring patients with PSC. That includes patients, caregivers, clinicians, researchers, as well as patient advocacy groups. And so we've organized this webinar today to have this conversation about what should we be doing, what are some of the steps that we need to take to promote health equity in PSC. There's a lot to be done, but it needs to start with having this conversation with all parties involved. So we will move forward with the webinar.
I'd like to introduce Monika. She's a patient with PSC. Monika, please turn your camera on. How you doing?
Hello, thank you for having me. So I believe I'm supposed to go ahead and talk about, from my perspective, the barriers and suggestions for increasing health equity. So my story is I was diagnosed with PSC when I was in my 20s, and I was very quickly told that PSC was, statistically speaking, a middle-aged white male disease, but I was a young Latina in my 20s. So I had lots of questions about how I fit into this world and where I could find information. Because I am a light-skinned Puerto Rican who lived in major cities, who has been educated and taught to assimilate into predominantly white spaces. I was able to have an education. I'm college educated. I was able to have insurance. My in-laws are actually in the medical field, and my husband learned early on to always have the best insurance because he grew up with stories of people with catastrophic stories. I'm actually an anomaly in the Hispanic Latino community because we know from research that at least 50% of those who identify as Hispanic, which includes many races. Hispanic is a government ethnicity label. So also thinking about what do the labels mean and who's identifying under them. That 50% of folks who have identified as Hispanic do not have insurance. And to me, that is when we talk about aspects of the key factors to help navigate my care. The fact that I had really good insurance allowed me to circumvent the system. I was not referred to a liver specialist early on. I went to specialists on my own. I went to a dermatologist around the PCP who saw me initially, and they're the ones who did the testing that led me eventually to a liver specialist. So I do know that insurance can make the difference between diagnosis and not. My story is one that shows that. So for me, a key component to increasing access in not just the Latino community because of the low rate of insurance, but any community, is to have insurance. So for me, not only personally seeking out insurance if you are in the best that you're able to get as a patient, but also continuing to advocate as a society-wide level for access to insurance for all folks, and that all people are able to do things like see a specialist. Because I've heard myself stories of folks who are really scared about going to a specialist, unable to afford to go to a specialist, or can't get a referral to a specialist. And by the time that their autoimmune liver disease is discovered, it was too late. So that's my number one takeaway from my own story. I think it's also really important to understand cultural messaging around what it is to question authority. So I had already had that training to question authority, and that is not the Puerto Rican culture. That is not a cultural norm within my culture. But it was essential for me to go around my doctor, initially the first doctor that I saw, in order to say, I think there's something else going on. And for many people, that is something that is a challenge, that you're taught not to question authority. So culturally speaking, I think that's really important to keep in mind. And also, what are the resources in order to get specialized care? Living in major cities, having the ability to fly to a Mayo clinic to get second opinions when they thought I had cholangiocarcinoma, and eventually to get my transplant. These are all barriers that are present to folks in order to get care. So the advice that I would give PSC partners, in addition to those, is also thinking about continuing culturally relevant education, not only for the organization, but the community. One thing that's important to know, I think, about marginalized communities is that we often enter predominantly white spaces and say, am I safe here? Am I welcome here? And microaggressions do happen. They have happened to my husband and I at conferences. So it is something to continually be aware of when we are asking, where is it that we are welcome? Where is it that we belong when we enter into a new space? So constantly being able to look at those things. I think also I've met someone whose mom did not engage in supports because her language of comfort, she both spoke English and Spanish, but her language of comfort was Spanish. So thinking about our materials being translated, are they available to folks in their language of comfort? Because sometimes, medical English is intimidating, but especially if it's not your native or language of comfort and understanding, which can mean many things as far as what language and what home languages are. I think also sponsoring more research in marginalized communities. So within the Latino Hispanic community, it is an ethnicity. Like I said, there are white Latinos like me, there are Black Latinas, there are many indigenous cultures within the Latino culture. So thinking about how do we know what's happening within the Latino community? How do we know what's happening? Because right now, as we've done research, as you guys have asked me to do before to do presentations, there's really not much out there. There isn't any information about autoimmune liver disease. Dr. Kidist showed that we do know that there's less access to transplant, but we don't know why. So I don't think we can fix that until we've had that research. And finally, suggestions for providers is, again, thinking about our own implicit biases. And these are something that all of us hold, that we've all grown up with, that I've grown up with, that take a lot of work to examine, a lot of work to overcome, a lot of work to consistently be watching out for. And it's one thing for the general population to have, but when it's your doctor that holds implicit bias towards your community, then that becomes really dangerous. So one of the things that goes around in communities, I know in my Moms of Color community, it comes up a lot, is if you are in a doctor's office, so this is to the advice to other patients, if you're in a doctor's office and you ask for a treatment or a test and it's denied, to always have them document that you've asked for that treatment and you've been told no, because that's a really important thing to just continue to examine. And I think that is all I wanted to say.
Thank you very much, Monika. Kidist, I don't know if, are you introducing the next speaker?
Yeah.
Okay.
So I think Frank is on. I was going to ask Frank to turn on your video. So we have Frank, who's a caregiver, who's very engaged and has been very involved in the care of his significant other with PSC. Frank, are you here? I just want to make sure that he's on.
Yes, can you see me?
Oh, good. Thank you. So, well, thanks for joining our program today. So I was just going to have you kind of let us know what your experience has been in terms of monitoring and navigating the care of your significant other with PSC, and if you have any comment or feedback or recommendation to researchers, clinicians, PSC partners, other patients or caregivers, that would be helpful. So I will let you speak.
Sure. Well, thank you for this opportunity to meet with you all. And I would say that as a caregiver, I guess came across a number of obstacles, and really what I took on is we're going to take this on head on, and I would treat myself like if I have this disease as well, right? And what we found is that attending the conferences and so forth, we needed to find a healthcare that had an expertise local, and that was a problem. We had to pretty much drive almost an hour, and we made the pros and cons and said, you know what, it's a high priority that we find the best care, and we're going to endure with this. So basically that was not having local care was a big problem. So as we worked on, I took on the task of making sure that a priority would be that my schedule would be, I would adjust, make sure that if I had to take a meeting, I would basically get in there on time so that I could be remote and certainly be there to support my wife. And that was really critical. Be there to hold her hand, support her. And we found is that, the latest research showed that there are a lot of things that are showing us risk factors. We started looking at diet. We started looking at exercise, stress. And I said, from my point, what can I do to reduce the stress? And indirectly, this is really critical, right? And so certainly we took that on as well. And we started monitoring as we went on. Is it working? Every 3 months, the blood work comes. Is it working? We continue doing it. And then we start peeling off the layers of the onion. If it's working, we continue. And there are so many things that we were far apart, but it was a real shocker to hear about this disease. But it's like, let's attack it together. And that's really what we've got. We've got an excellent doctor. We've got a good support system leading in the research. And really that was important. They really cared about really what was going on. And that made us feel comfortable. So I think just that really has helped. And I would say to patients with PSC, really attack it in a similar type of way, right? You have, if you're a caregiver, certainly support your loved one. And certainly if it means changing your diet, exercising, walking with them, certainly doing whatever you need to do to support them, it makes it easier. Remind them, did you take your medication? Do you have an appointment coming up? All those things are really important to be that you're fighting this thing together. And I think a message to, the researchers is like, in dealing with underrepresented community, certainly make it, assertive action to basically go ahead and try to find out what's going on with this. The key to what's going on with this disease is a tough one, but we have smartest minds looking at it. And the clue might actually come from these. Maybe it's accelerating more or it's accelerating less, but certainly look at this underpopulated, represented population and certainly continue to drive it. Make them feel comfortable when they attend. If they're not seeing more people like this, maybe consider opening up a group. And certainly as we conquer this thing, I would be certainly welcome the idea to help make others feel comfortable as well. I think that's really important. If you go in and you're the only one, it's like, nah, I'll deal with this by myself. No, deal with it with others that are just like you and make you feel comfortable. It's really key. You're on mute.
Sorry. You raised so many great points that we will revisit in the Q&A session. Anything for researchers? So you did comment for other patients and clinicians?
On the research, the trials, that certainly, I think, data, the answer is in data, right? And as you look at it, if you're not looking at a certain population, you just don't know what is going on. So make it an effort to make sure that the whole population is represented. And certainly, and then follow up and basically do what you need to do to basically get some information from all the whole cross-section of the population. It's really key. And underrepresented or, underprivileged, they might have some problems getting transportation or a supporting system. That will be something that we support and make sure that they get to their appointment, and make sure that they follow up and so forth would be key.
Thank you.
Thanks.
Thank you so much, Frank. Willie, do you want to introduce Celeste?
Sure, absolutely. I have the great pleasure to introduce Celeste. Celeste is a patient living with PSC, and she's going to talk to us about barriers of care and how she overcame them, key factors that help her navigate her care, and advice for other patients. Celeste, please turn your camera on.
Hi. Hello, everyone. I apologize. I got our timing wrong, and that is my fault. So I am just walking in. I just listened to my husband finish his portion of his presentation, and actually he covered quite a bit of what I was going to cover. So I'm grateful for that. I think the barriers for me, and once again he covered it, was finding a doctor in our community that specialized in PSC. So that was one of the barriers. And we were fortunate enough to do the research and do the research, do the research and find a doctor about an hour away from us. And so we made it a point, as he indicated, that to make my health a priority. And so if that meant traveling to an hour away, then that's what we needed to do. But then again, the commute became a barrier. And also his job, as he said earlier, was also a barrier, finding convenient days and times to schedule appointments where we weren't affected by traffic or getting in to see the doctor at a time that was convenient for him and his job. So those are a couple of initial barriers that we had to overcome. And then in terms of advice that I would like to give other PSC participants, clients, is to really research, right? Do the research and find out what it is that, as much as you can, about PSC. And then after you have done that, then you want to find out as much and ask the doctor questions. Don't be afraid to ask the doctor questions and find out the answers to them. The other thing is that find a doctor that will listen to you, is willing to listen to you, willing to work with you, listens to your concerns, and partners with you to find the best treatment. And as my husband said, attend conferences, find out as much as you can about PSC, ask the questions again, attend trials, ask about trial medications that may help, and make the lifestyle changes. And so those are some of the lifestyle changes, as my husband said earlier, diet and exercise. So thankfully, he said some of the things that I had on my agenda. In terms of the PSC partners, I reiterate to find out what is important to them, and then address those issues. Really inundate the community with information and address those concerns. Find out what the concerns are. See if you can address those concerns. And some of them may again be transportation and job, insurance issues, and even creating a safe environment for them to be able to be transparent, be able to share their struggles and concerns. And so that is, again, I apologize for being late. And I think that is about all that I have to share. Thank you so much.
Thank you, Celeste, for... Go ahead, Willie.
No, that's fine. Go ahead. I appreciate Celeste's comments as well. You know, it's nice when married couples are on the same page. That makes dealing with things a lot easier. So they both gave great advice. I have the pleasure of introducing Dr. Cheng, a caregiver, and she's going to cover some of the same topics. Dr. Cheng, we're looking forward to hearing from you.
Hi, thank you very much for having me. I think that talking about barriers of care, I'm sorry, let me back up just a little bit. So I'm a physician. I do work in the hospital setting. So it was my younger sister who was actually diagnosed with PSC. And unfortunately, I think for her, when she was diagnosed and when she started having her symptoms, it was during the beginning of the pandemic. So it was right when things, soon after everything has started shutting down. And so then for her physician had tried to take care of it outpatient, and they were trying to figure out what was going on with her for several months before she actually went into the hospital. So when she went into the hospital, then we're talking about COVID, everything shutting down. There's no visitors. We can't see her. At the time, she was also, she also had this foggy brain where it was difficult for her to remember things, even though she's able to talk to you and be able to explain what she thought was going on. So everything kind of seemed coherent But in the back end, and what we ended up noticing later after she had already been discharged from the hospital, was that a lot of those missing pieces were as a result of everything that was going on. One of the things that we ended up finding out when she was actually when she was in the hospital was the lack of a communication between one physician to the next. And I think it happens probably too commonly within healthcare, is that one doctor will say, okay, this is what we think that we should be doing for the patient, is given to the patient in the hospital. And then when she left the hospital, she wasn't given those medications. And then it was always someone else who was going to give her the medications that she needed to take care of her illness. So, and then in addition to that, I think some other barriers that we ended up encountering in terms of coming to her diagnosis were just system issues. Just how is it that certain hospital system or certain healthcare systems end up diagnosing what kind of things will they actually do, and in what order they would actually do their diagnostic procedures in order to come to a diagnosis. So I think we ended up butting heads frequently with her providers in order to try to get her the care. But I think that kind of goes also into some of the things that we should be talking about, which is what are the factors that will actually help you in terms of navigating care. And I think one of the big things that I think Celeste and also Frank had also mentioned too, and I think everybody else, which is that we need to ask a lot of questions. And I think part of it is when all of this happens, everything is new. And so when everything is new, there's so much information, so many different components that we have to pay attention to. And so how do we end up asking questions and then synthesizing all of that to create these hopefully informative and thoughtful questions for our providers? And so I think one of the things that we ended up doing was just taking a lot of notes, because I think one of the things that even I, as a healthcare provider who's familiar with these medical terms that physicians use, I would, after a while, if it's been a month or two since our last appointment, is referring back to those notes saying, hey, this is what we talked about. This is the plan that we're going to have. And in order to make sure that our patient is taken care of, and then what are the next steps? So all of those questions, continue to ask those questions and take notes, because we will need to refer to those notes just to remind us, because our memory does change over time too. I think one of the things that we ended up also finding was that our providers are also our biggest advocates, right? So they're the people that will go in and say, hey, this is what we need to do. So I think having that open communication, asking things in a non-confrontational way in which we can actually be successful with trying to get to our end goal, right? And I think, because I think sometimes what ends up happening is that we get overwhelmed, and then we go to the space where we think that people are doing things and they just don't understand, and that may be the case. But I think also give people or providers the opportunity to answer those questions that we may have and to address those issues that we do have.
Dr. Cheng, so sorry for interrupting you. You certainly have great insight being a provider and also a caregiver, and would love to hear more of your thoughts, hopefully in the Q&A session. I'm going to introduce Dr. Bowlus next. And Dr. Bowlus, do you mind turning on your camera? So Dr. Chris Bowlus is Chief of Gastroenterology and Hepatology at UC Davis, and the Lena Valente Professor of Medicine with dedication to PSC research and extensive experience in caring for patients with PSC. Do you mind just reviewing where are some of the gaps about our understanding of healthcare disparities in PSC and any research work that's currently going on? Thank you.
Sure. Thanks, Kidist, for the introduction. Really happy to be here this evening to talk to everyone on the webinar. As Kidist mentioned, I've been studying PSC for some time now, And one of the main focuses has been on some of the disparities or differences we see in sort of the non-European, non-white populations. And if I just, comment real quickly, that I think the sessions or the discussion so far has really been pretty impactful in terms of some of the barriers that people experience in PSC. And it's not unique to PSC. I've worked also in hepatitis B, and trying to overcome these disparities in a systematic way in a very common disease in that setting can be quite difficult. And even understanding disparities can be quite difficult. When you talk about a rare disease like PSC, it gets even more difficult. It's hard enough for us to sort of get wrap our heads around how PSC progresses and understanding the disease. And then when you talk about, cutting it down into smaller groups, it gets even more difficult. So that in itself is just a really big challenge for us. But we looked at the UNOS data almost 15 years ago now, and we saw that the frequency of listing for PSC among African Americans relative to non-Hispanic whites was really the same. And that was the indication to us that PSC was, relatively as common in African Americans as in non-Hispanic whites. But we did see that those listed for liver transplantation tended to be younger and had some other characteristics that were different compared to whites, in that they had lower rates of IBD reported and were less frequently men. As you know, PSC tends to be about 2/3 men, 1/3 women. But in the UNOS database, it was almost 50-50. More recently, there are some study out of the UK, which looked only at those with IBD. So they were able to identify PSC patients within their national database that also had IBD. And they sort of confirmed our previous findings with the UNOS database that their Afro-Caribbean patients with PSC and IBD were younger, and they also showed that they had worse outcomes when you looked at transplant or PSC-related deaths. What we've been doing so far in North America has been in our consortium of 19 centers, mainly in the US, but also one center up in Canada, and looking at what are some of the differences in terms of PSC among non-Hispanic whites, Blacks, and Hispanic whites, And so far, out of about 850 patients, we have 85 that have identified themselves as Black or African American, and about 50 that are Hispanic. So not a large number to analyze. We do, though, again, see that African Americans have a lower transplant-free survival. That is, have a lower chance of living or getting a transplant over time. What we haven't found in this group, though, is that they are diagnosed at a younger age. We again found that they have lower rates of IBD, but no difference in rates of colonoscopy. So what had been sort of criticized in a previous analysis we did of the UNOS data was we didn't know if people had colonoscopies or not, but now we do. And so it's not a matter of not diagnosing IBD, it just seems to be less frequent. And we also looked at if there was a delay in diagnosis that might be explaining this difference. And when we first looked at the data, we did seem to see a delay in diagnosis among African Americans from the time of their first abnormal liver test to the time they actually received a diagnosis of PSC. With the more up-to-date data, we're not seeing that. And I don't know if that's because more recent cases we're kind of overcoming that, lack of awareness of PSC among different groups. but we're not seeing that right now. So we do know, like I said, that African Americans tend to have worse outcomes. We don't know that about Hispanics. We just don't have enough cases to really analyze the data. We're still trying to figure out where are the barriers, what are the causes of this disparity. Is it lack of access, as we've talked about, barriers to access, or is there something biologically different? We know that there are differences in some of the characteristics in terms of younger age of onset. We know that there's less IBD. I should also mention, at least in terms of the main genetic risk factor, it's the same between African Americans and whites. So we, at least regarding that, it's no different. So lots more to understand.
Oh, I agree with you 100%. And I think that you will get some very good questions during the discussion. But I also want to thank you not only for participating, but for the research that you're doing, because it's your research that puts numbers behind the feelings and the anecdotes. And ultimately, I know and I'm confident that you will identify the barriers or be one of the people. So thank you very much. I have the great pleasure to introduce Dr. Lewis Roberts. He is a professor of medicine at the Mayo Clinic in Rochester, and he's going to talk to us or help us understand some of the gaps in understanding PSC and cholangiocarcinoma and their impact on underrepresented and disadvantaged patients with PSC. It's all yours, Dr. Roberts.
Thank you. Thanks very much, Dr. McKinney. And again, it's a pleasure to be here and to be participating in this webinar. And I would particularly like to talk about PSC and the fact that, a fair number of people with PSC will have progression to developing cholangiocarcinoma or cancer in the bile ducts. And as Dr. Bowlus has mentioned, it can sometimes take a while for people with PSC to be diagnosed with the disease. And I think part of this comes from the fact that in many of the underrepresented and disadvantaged communities, and particularly in my experience in the immigrant communities from Africa, for example, that live here in the United States, there's really very little awareness of PSC as a disease. And in some cases, as Dr. Bowlus mentioned, PSC can be associated with ulcerative colitis, but ulcerative colitis often presents with diarrhea, sometimes with blood in the stools. And in many of those communities, diarrhea with blood in the stools is interpreted as due to an infectious disease or a dysentery, not to an autoimmune disease such as ulcerative colitis, for example. And so consequently, it may take months or sometimes years to arrive at a diagnosis. We've been working also on some genetic studies to try to understand whether there are particular inherited variants in our genetic code or our DNA that make us more prone not only to PSC, but within the context of PSC to cholangiocarcinoma. And while most of this work up till now has been done in populations of European descent, we are now embarking on a project to recruit persons with PSC and PSC with cholangiocarcinoma in Africa or in communities of African descent in the United States, in Hispanic communities in Puerto Rico and Texas, and in communities in South America. So we hope that this will increase our knowledge of the mechanisms that lead to development of PSC and cholangiocarcinoma in these communities. One interesting observation we've made, for example, is that systemic lupus erythematosus, or what we typically colloquially call lupus, is a disease that's actually recognized to be quite highly prevalent in persons of African descent. In our recent studies, we've actually found that people who have genes that are associated with high risk of lupus are also at higher risk of developing PSC. So there may be, connections between these diseases, particularly in individuals of African descent. And we think that observations such as this may help us to identify people who otherwise would have unidentified PSC. Finally, how do we enhance the awareness of communities of these diseases? And one of our community programs in Minnesota, which we call the Somali Health Advisory Committee, or SHAC, has been focused on increasing awareness not only of viral hepatitis, which is a more common liver disease, but also of other liver diseases in the immigrant African communities, including the Somali communities from Ethiopia, Kenya, and Liberia, where we have fairly high numbers of these persons in Minnesota. So we're working to provide education to the community about not only the common liver diseases, but the less common diseases such as PSC as well. And I think I'll stop here.
Well, thank you, Louis, for your dedication in studying cholangiocarcinoma, genomics of that, and also your efforts globally, and particularly in Africa. I know you're doing so much work, and you and I both have heard that, for example, in South Africa, it was an eye-opener that one of the most common reasons why people get transplanted is PSC. And so we really need to expand our effort, not only just in North America, but globally. And hopefully we can all work together to study that a bit more and increase awareness. So with that, thank you so much. Again, I will introduce our next speaker, Dr. Kim, who is a clinical development lead, has been part of multiple clinical trials involving PSC, and we want to hear her comments about what have been your experience about including diverse patients or being able to recruit diverse patients in PSC clinical trials, and if not, what should we be doing? What are some of the extra efforts we need to add to improve that? So I will let Dr. Kim speak.
Thank you, Dr. Mom, and thank you, PSC Partners, for the invitation to participate in today's webinar. I'm thrilled to be here with our panelists to talk about these important issues and topics in not only in PSC, but in drug development. Apologies in advance, I'm just recovering from a small cold, but having been in clinical development and in industry for the last 7 years, predominantly in hepatology and across 3 PSC drug development programs, many of the things that the speakers have already spoken about in terms of the patient care or access to care or even the research that's being done resonates very much with the things that we do in biotech and industry, and maybe it's not specific to a particular underrepresented or minority or DEI group, but a lot of the things that I've seen that we've done in recent trial development tries to think about these things as we develop a trial for PSC, knowing that there's a very variety and diverse group of people who do have the disease, but also in conjunction or in thought of the patient community and the patient population that are able to enroll in these particular studies. We know from previous webinars and events that we've had together with PSC partners that drug development is difficult because of the small numbers and because there's not a lot known for PSC in general, but even more so in people of color or other underrepresented groups. So we're highly dependent on Dr. Bowlus and Dr. Roberts' research in the space to further our knowledge about the PSC community and the disease course and the experience, so that we could also help target therapies for treatment of these things. So I'll just speak briefly on some of the things that I've seen happen in drug development for treating or for preparing for PSC programs. And some of the things that we've done in my experiences first and foremost, partner with the regional PSC patient advocacy groups. So personally, I've partnered with PSC partners a number of times to be able to talk to them, Ricky and Joanne and Rachel, to be like, hey, we're thinking about this study. Can you take a look at our program or our study to give us your patient's perspective on how this would be either a burden or not a burden, or things that we haven't thought about for the patient experience as they participate. So I think that's one big thing that we have leveraged in terms of being able to understand the patient experience and trying to encourage participation in these studies. Another thing that we do, and this is not specific to PSC, but in general, is to, the cost to participate is usually zero for the patient, other than time and being able to get to the site, which is also, we've already heard a barrier at times. But the actual medication or asset that's being developed, there's no cost for the extra procedures that are being done or the extra blood draws or any of those things. And many times the programs will, implement travel concierges or at least travel reimbursement programs, so that whatever money that you do spend to get to the trial site is also returned back to you in reimbursement form. Other things that I'd like to see happen more often, and I look to do that in the next, in the next programs that I'm going to be participating in, is to partner with, regional DEI, hepatology experts or whatever the indication is, to further understand the regional and community specifics of what the underrepresented groups are, to further address and be able to help their participation in studies. Monika had mentioned earlier that she had really good health insurance, and to that extent, since clinical trials are typically free to participate in, it might be one way to, bringing awareness to the study might also be able to bring a bit more healthcare to the patient who may or may not be able to have coverage, typical coverage as they usually have. So they'll get they'll get seen by the doctor more often, they'll get tested more often, and potentially that care could also translate to improved outcomes. And so lastly, depending on the region and the site, maybe in a different country or even in Miami, say there, or Houston, or other places where there's a lot more diversity, translations into Spanish or other languages have been done in our programs. When we're in Israel, we've done Hebrew, Russian, and I think Arabic to address all of the different communities that are represented there. And then other conversations that programs I've have had are things like, do we provide a device if we have some sort of questionnaire that we want them to answer all the time, or do we do it on paper? What's the advantages or disadvantages of doing those two things, or asking a patient to do the questionnaire on their phone, because all the same questions about access and internet access, technology access, all of those things come into play in terms of being able to have a successful clinical trial. And so I'll stop there, since I'm sure there's more to talk about at the question and answer session, but thank you for your time.
Thank you, Dr. Kim. I'm glad that you're doing what you're doing. You said some very interesting things. I'm personally aware of some historical and cultural reasons why certain groups are hesitant to participate in clinical trials. And I know that you mentioned that, and you'll get more questions later on. So thank you very much. I have the pleasure of introducing Dr. Costello from Chemomab Therapeutics, and she's going to talk to us as well about clinical trials and DEI. Welcome.
Thank you so much for having me. And I think a lot of the experts on this panel already share some of the thoughts that I'm going to share with the group. But I want to change my focus a little bit to share my past experience as a transplant clinical pharmacist, as well as the director of clinical research, practicing in Memphis, Tennessee, where I've seen a lot of African Americans for transplant. And the reason I want to share that is one of the key things that I always tell patients is we need diversity in our clinical trials, is because a lot of these different groups, their drug metabolism may be different. They may handle drugs differently. How I need to partner with investigators, with researchers, and with industry to develop drugs that is really that we have a good understanding of how they will manage the medications. Are they going to have the similar side effects? Do we need higher dose? And I personally have seen that in African-American patients where they need higher dose immunosuppressant. They develop side effects a little bit differently. So one key thing I want to encourage patients on here is really consider clinical trials and participating, because they bring a lot of value to these different groups. An example I also want to share was I also work in other rare diseases. And, one that's dear to me was IgA nephropathy, where it disproportionately affects Chinese patients. Unfortunately, only 2% of Chinese patients actually enroll in clinical trials. So when we develop this drug that's going to be on the market, I won't be able to know if it's going to really benefit Chinese patients, because their natural history of the disease may be different. They may respond differently. And I think, as Dr. Bowlus and Dr. Roberts have mentioned, there may be ethnic differences in other subgroups as well. So we really need that diversity in our clinical trials. So having, sell my a speech about, the importance of diversity, I want to switch gear a little bit about how I bring my clinical and research experience into the drug development realm. Is I think one key thing is, as a sponsor, we really need to work with patients and investigators to understand what are the barriers of having patients enrolled in our clinical trials. How do we engage them earlier? How do we design a trial so we address unique aspects of these patients? And I think one thing that I hear loud and clear, and that's one thing we plan to do, is the basic is, how do we provide concierge service to ensure that patients who are interested in participating in clinical trials, investigator thinks they're are good candidates but live too far away. So as a sponsor, I think we can definitely assist in that to ensure that the right patients can enroll in the clinical trial, support the investigator, support the coordinator, and support the patient. I think that's at the bare minimum of what we can do. However, one thing that I want to get input from this group is, what about a patient advisory committee or an advisory group looking at all these different ethnic groups? I think diverse group, because I think we can learn a lot from a cultural perspective. How do we communicate clinical trials to these patients? What are some of the concerns that they may have? And I've worked with Chinese patients, I work with African-American patients. There's definitely cultural concerns that are unique to these groups that we as sponsors and investigators should definitely try to address and get their input. So I think maybe having partner with PSC partners and having an advisory board and get their insights may be valuable. So with that, I'm going to wrap up because I think we have lots of time for, so I want to save some time for Q&A.
Thank you, Dr. Costello, for your insight. Your experience is really valuable, and we would love to get you engaged and get input on PSC Partners' effort to promote equity as we move forward. With that, I do want to introduce Joanne from PSC Partners. Joanne, are you on? So we... I know PSC Partners has been putting a lot of effort and emphasis on promoting health equity in patients with PSC. And do you mind kind of giving everybody an overview of what we are working on and what's coming up, please?
Sure. Thank you so much, Dr. Yimam. I'll begin by saying PSC Partners welcomes everyone to all of our events. The annual conferences were always amazing, and nothing is more beautiful than seeing someone meet another person with PSC for the very first time, often with tears, laughter, and hugs. Since the pandemic, we haven't been able to have in-person meetings, and yet those virtual events and connections made our mentor program All of these have helped us reach out to many who we've never met in person. In 2020, we had a PFDD, a successful effort where FDA, pharma, researchers, and clinicians heard the voices and the stories of PSC patients about what it's like to live with PSC. Yet, despite efforts to reach out via social media, our community and the PSC patient registry still does not reflect the diversity that we need to achieve. For successful drug development and clinical trials, we must expand and include everyone impacted by PSC, and each of us can play a role in this endeavor. We need to be diligent, aggressive, and creative in our efforts to find and connect with those living with PSC of every race, ethnicity, and gender. Dr. Mom had asked me about identifying and mitigating health inequalities in PSC, if that is a research priority. And the answer is absolutely yes. We're determined to weave DEI into research and everything else that we do. The PSC Partners Statement on Diversity, Equity, and Inclusion is posted on the website. We're building relationships with physicians who care for those who are underserved and underrepresented, and with clinical trial researchers in industry to increase diversity and inclusion in PSC trials. We're collaborating with hepatologists to increase diversity in the patient registry. And for those of you who have not yet joined the registry, PSC Partners Registry staff is there to answer your questions and talk about your concerns. We have developed 2 major research initiatives, and DEI is woven through both. The Worldwide Integration of Natural History Database, known as WIND, will build a diverse population of PSC patients. The development of a PSC-specific patient-reported outcome measure, the PROM project, will bring diverse PSC patient perspectives and symptoms into clinical trials. DEI is woven throughout our 5-year strategic research plan, and we will use our patient registry to measure success in engaging underserved PSC patients. This webinar is just the beginning. We will be adding additional webinars and focus groups to identify people's needs. We'll be sending you an email with more information, and I do want to mention our virtual peer-to-peer Zoom room, the very first, Celebrating Diversity in PSC, January 11th. In closing, we are the ambassadors of change. Together, our voices will continue to be heard. Your presence today makes a difference, and as we grow and develop new ways to connect with more people living with PSC, to support each other, and to use our collective voices to influence FDA research, clinical trials, and advocacy for PSC, we will build more opportunities for finding treatments and a cure, as well as improving the lives of everyone with PSC. Thank you all for being here tonight. Dr. Yimam.
Thank you so much, Joanne. I've been on the board of PSC Partners for a number of years, and I tell you, this organization is so forward-thinking and so impactful, and it is truly an honor to serve on the board. So thank you very much for that presentation. So I guess we have the honor of starting the discussion, kind of summarizing what we heard, and then asking a question or two, and then unleashing the questions, I guess. Is that how we're going to operate here?
Yeah, I think as we've heard, there are so many variables to tackle, and it's going to take a village. It's going to take everybody surrounding a care of patient with PSC. And this is just the initial conversations. There is so much to talk about, and we look forward to having multiple programs to tackle one thing at a time. But I think for the interest of time, we should have our panelists to turn on their cameras and go over some of the questions from our patients.
No, I agree 100%. And I got to put a big question out there too. And it may be the last question or the beginning question. And that is, what I heard was we're documenting, quote unquote, the situation very clearly. You take anecdotal comments, individual experiences, but for researchers like yourself to really get your arm around the situation, you have to do studies and ask questions. And you're dispelling the myth, right? This disease is only in XYZ population. The next step is identifying the barriers. And my big question is, how do you do that? Who's doing it? And who's knocking the barriers down? So you can take that. I know that's a big one. That could be the last question because we have some other questions from our listeners, which you may want to handle first, and I'll leave it up to you. Kidist, are we asking the questions? Do you know?
Yeah, so I'm gonna ask the first two questions. Perhaps Dr. Lewis, Robert, and Chris can answer it. Is cholangiocarcinoma rate of cholangiocarcinoma, is that higher in patients that are African American with PSC? Is one question. Maybe Lewis, you can answer that.
Yes. So it's quite interesting. I think the data suggests that the rate of cholangiocarcinoma is not higher in African Americans. It's likely about the same or perhaps even a little bit lower in African Americans than it is in non-Hispanic whites. Comparing the different races, I think the data suggests that the rate in Hispanics actually is higher than it is in non-Hispanic whites. What is different though is the outcome of patients. And so we know that African Americans have a significantly worse outcome than non-Hispanic whites. It's about 20% worse for Blacks, and outcomes about 10% worse for Hispanics.
Is there any difference in terms of overall outcomes in cholangiocarcinoma that's non-PSC related versus PSC related?
So that's a great question. I think it's very variable, depending actually on the patients having been diagnosed with PSC or not. So individuals who are diagnosed with PSC are recognized as being at high risk for cholangiocarcinoma. Their doctors are often following them very carefully. And so often we can diagnose cholangiocarcinoma at an earlier stage where we have often more effective treatment. On the other hand, individuals who just happen to develop cholangiocarcinoma without known risk factors often are diagnosed quite late because they don't have no one's following them for development for detection of early cholangiocarcinoma.
Thank you, Lewis. Chris, I think you were talking about that based on the data from the Northern America Autoimmune Consortium study. One of the questions our patients had here is, what are the differences in outcomes in minority patients with PSC that we know so far? Is there anything that you can add?
Yeah, I think that the main thing we can add, we has been pretty consistent, is that if we look at transplant-free survival, and just to clarify what that means is when we follow patients over time, from the time of their diagnosis to an outcome, what percentage of them over time have not reached that outcome. And typically when we look at liver disease, we use something called transplant-free survival. And that's because if someone gets a transplant, they don't die, but it is an important event. So if a patient dies, then that counts as an outcome, or if they get a transplant. So the longer you go without getting a transplant or dying, then the better the outcome is. And we know by using that endpoint, those outcomes, African Americans do worse. They have higher rates of either transplantation or death. Now, and that's been also seen, I should say, again, in the UK, but restricted to those with IBD of Afro-Caribbean descent. Now, one of the things that came out from the UK study was they counted only deaths that were PSC related. When they looked at all-cause mortality, they did not see a difference. And what we still don't know is, are these differences due to lack of access to transplant? Which is universal for all indications for transplant, so it may not be unique to PSC, or is it other causes? And that's still an unanswered question for us. So clearly differences, we know that, but we're still kind of trying to dig into what those differences are due to.
Thank you, Chris. Will you feel free to pick up some of the questions and ask our panelists. So one other question here that is listed, it might be for Joanne and also to providers. Our patients are asking us, how could they help spread the word about PSC to others? And how could they also spread the word about PSC partners? How do you want our attendees today to help?
Could I ask from Dr. Bowlus, Dr. Roberts, do you have things that, how could we help you as physicians connect your patients with PSC partners and spreading this word?
Well, I think that, I guess the question is when you say spread the word, there's I would put words out there because I think we've talked about a lot of different things here. One is just awareness of PSC, so we get increased diagnosis, understanding of PSC, and the breadth of the groups that are affected by it. And then the other piece we talked about, including barriers, are participation in clinical research, whether that's either just observational or clinical drug studies. So there's lots of different pieces there. I think getting the word out about PSC in general is quite difficult because it's a rare disease. So I think the advantages that we have in today's society is, targeted advertising can be pretty powerful. You can't advertise on the TV. You can't put it in the newspaper. Well, newspapers don't exist anymore, I guess, but you can't do broad advertising for this sort of thing. You can try to increase awareness among physicians, but, even a hepatologist only has a handful of patients that they follow with PSC. So it's really difficult. It's a real challenge for everyone, I think. But it's kind of that, just making sure you get the word out as far as possible. And maybe there are some innovative ways with more digital advertising. I would say also, though, that in terms of the discussion we're having today, a lot of this it has to be members of the community that go out and talk to the individuals with this condition. I mean, I've learned that not only in PSC, but as I mentioned in hepatitis B, you have to partner with those people in the community that are, knowledgeable and trustworthy to discuss this. And again, this is a real challenge in a rare condition like PSC, but you need some champions to go out there and spread the word.
One question, and I'm maybe going to group three questions together because you touched on some of it. To what degree can technology be used to engage people? We learned a lot from the pandemic, telehealth. I just found out that there are certain insurance companies, there's no deductible if you do telehealth or, and things like that. Is that something that can be used? And then I'll throw another question out. We talked about cultural barriers in general, and this question is asking, do we know exactly what those cultural barriers are? Okay, I'm saying head shaking, but let's.
I think I'm going to jump in a little bit just because I'm echoing what everybody just mentioned, and also past experience is community-based for outreach. It's the fundamental, it's the baby step, right? I think we need to start with community outreach. I was thinking about similar rare diseases, increasing awareness just in a health community center or church group. Sometimes that kind of creates like a health forum as a start. Sometimes that will help. And then what the cultural barriers are, participating in, different diseases, there's a mindset, depending on the disease or the organ that's affected, that certain ethnic groups are hesitant to share, either with their physicians or with their family. I think those barriers, we need a deeper understanding.
And I would really, really love to see, and to see us work diligently, even say if it was with Dr. Roberts, Bowlus, and Yimam's clinics, to find people who are close in that area, to maybe figure out a way where we could somehow talk to a group of your PSC patients, or as Dr. Costello was saying, be there as part of the community to gain trust. And so any innovative, maybe even crazy idea for how to do that at some of these big medical centers seems like it's possible. Am I wrong? Or too optimistic?
No, I think, Joanne, you're bringing up a good point that was raised by Celeste and Frank, that they enjoyed seeing patients that actually look like them and have creating that peer support group either at our own centers, which we have, and also engaging those diverse patients that we are seeing in our clinic with PSC partners, so that you have more people attending, more diverse people attending the Zoom session that you're creating, that will serve as a base for engaging others so that they are more empowered, educated, and supported. They won't be scared. And so you can buy that trust. I think creating the peer group and recruiting patients that are diverse and more engaged will help and support others that are going through the same experiences, but not having perhaps the support they need.
Are any of you guys aware of studies that are documenting the disparities in healthcare and delivery or outcomes for the LGBTQ community? And can you talk about those disparities and what they are?
That's a great question, and maybe I'll just have more of a comment than really an answer, which is that in part we've talked about ulcerative colitis, for example, and its association with PSC, and I think in part because of recognition by inflammatory bowel disease IBD group about some of the specific challenges that patients in the LGBTQ community face related to inflammatory bowel disease. They've actually just this summer launched a Pride IBD clinic. And with the idea of really just sort of focusing and really sort of creating a safe space and making patients within that community aware that, there's people here who are taking a particular interest in IBD in the Pride community and are willing to try to do the things that they need to do to better understand the disease in this context, and also then to work to improve the quality of care. And I think similarly, what we're doing, we heard as part of some of the work we've been doing in liver and biliary tract cancers, I've heard a lot from patients about the different toxicities that they face. There's financial toxicity, there's the side effects, there's, some of the challenges related to even pain medication and their fears about being addicted to pain medication. So we formed a partnership with one of the psychologists here and are trying to do a couple of things. One is going to the community and try to communicate and understand from the community, what their experience is of these toxicities and how we can work together to try to address them. And a substantial part of this has turned out to be the psychologists then trying to apply different types of like behavioral therapy and offer different tools to patients to see if those tools might help. So I think there's things we can do in partnership with the communities to try to address these issues.
One other quick question I have, my first question is still on the table, by the way. I know you guys have been thinking about it. But let's talk about FDA for just a moment. And when we talk about clinical trials, we're doing them because we want to submit that data to the FDA. What is FDA's thought on diversity in clinical trials? And are they pushing this as well? I just see heads. Anybody want to comment on it or talk about their experience with FDA?
I know that they're interested in it and have asked for some of the data we've been generating, but I'd be interested to hear from either Dr. Costello or Dr. Kim if they have any other insights from the industry side, what their experience has been.
Yeah, I can't say that I know their specific stance other than what Dr. Bowlus had mentioned, that I know that they're interested and they'll take any information or data that is more diverse than what has already been historically established. And there's more emphasis, but there hasn't been a mandate that I've seen come out to say like this has to be done. And I think it depends on the disease context too, because of like, again, the data that is out there that might suggest a higher prevalence in certain minority groups or ethnic groups as well. So would be, that's a little bit of homework that we need to do to go back to see what else they have out there for us.
Yeah, I think sorry, go ahead, Joanne.
Oh, I was just going to mention Global Genes had a conference just this week, and the FDA had a group of people from their diversity section who presented, and they are absolutely crystal clear that they do very much want diversity. And it was a part of the FDA that PSC Partners has not yet engaged in, but we now have their names.
Yeah, I think there's definitely mandates from the FDA to include diversity, but I think exactly how it interplay with a rare disease, I think that's another challenge, just because it's challenging enough to find enough patients to do a robust clinical trials for approval. And on top of that layer is diversity. But I know in some other rare disease where disproportionately affect a specific ethnic group, there's definitely more research on those that the FDA mandates, either a biomarker or other related types of research. But for PSC, I've not seen any that is specific. But Joanne, I would be interested to kind of learn more from that discussion.
Exactly. Yes, me too.
I think we might be running out of time soon. How about getting back to Willie's first question briefly about who's doing the studies, looking at the barriers, and we hear a lot about them. We don't hear a lot about implementing changes that would improve care. And so are we thinking about those?
I would say we're definitely thinking about them. We've looked at socioeconomic status, and that really hasn't come out as a factor. Fortunately right now not fortunately, I shouldn't say that. From a research perspective, that makes it a little easier is if there's not an effective medication, then it's really not an issue in terms of access to treatment that we have to think about being the cause of the disparity, right? And when we looked at URSO use, for example, it seems to be the same, if not even a little higher, in African Americans. So it doesn't seem to be that's driving this. But there's so many other things, and I don't claim to be a health disparities researcher by any means, and so, but I do think we can learn from other diseases what are some of the barriers that occur, in particular, like we talked about transplant in particular. There's a huge barrier to both getting listed and getting transplant. And then as you showed Kidist, the wait list drop was much higher for PSC. And I think that's true for just about every condition that's listed for liver transplantation. So again, not specific to PSC. There's a lot of things here we can learn that are probably very similar going on here. But I do think there is something else that's somewhat is also a biologic difference. which we don't understand. And that's going to be important when we start thinking about treatments also. There might be certain treatments that are effective or, more or less effective in certain groups. So we have to think about that.
My challenge is, I think you're absolutely right, but if we don't reach people and diagnose people, okay. And so my question, and we're probably out of time, is which institutions are implementing the policies and making changes and are seeing their metrics and their numbers go in the right way? Who should we follow? They don't need all the information. They're just making changes and they're seeing impact. That's the question that I have.
It's hard to do in a disease like PSC that's rare. I will say that we've, as I mentioned, in hepatitis B, just we're going over time here, but we have populations that are 15% of the population is affected by hepatitis B in certain Asian groups. And we instituted multiple systematic interventions to try to move the needle. And it is really, really, really hard to do. Both trying to, on the patient side, the physician side, the system side. And this is true for all sorts of disparities, having patient navigators, et cetera. There's all sorts of things out there in terms of trying to decrease the disparities. And it just goes, I think, to show that this is a systematic or systemic issue that we're talking about. And there's not going to be a silver bullet or anything else. And these inequities, as long as there's inequities in society, we're going to see inequities in healthcare, at least to some degree, right? I mean, there's biological variables for sure, but there's a lot of things that are just bigger that are really hard to address. Not to on a bad note or sour note, but I think that the size of the problem is quite large.
But I have to say that it starts out with our interaction with our patients in clinic, like, supporting the ones, for example, that need a translator. Make sure that you have a translator to speak to them. If they need more time, spend time with them. Clinical trials, they will take time to convince them what clinical trial is about and invest that. I think we can all start doing the small steps that will actually change care and hopefully move forward in addressing it in a systematic way.
Agree.
Thank you, Chris.
If I could say just along those lines, the more we get participation, especially in PSC partners from a broader group, it's just going to build on itself. Because, going back several years when we first PSC conference, I don't know, more than 10 years ago or whatever, it did not look like my clinic. And I think it's moved further, but it needs to go farther. And I think it just will continue to build on itself as more people get involved to, different backgrounds.
Great.
I'd just like to compliment PLC partners on this diversity initiative, because I think, again, it'll really help to move, to increase the awareness within the communities. So that people and their physicians even think of PSC as an option when they're faced with signs and symptoms that are relevant.
I think it not only provides support, it empowers patients to take charge of, their care, be active participants of their care. So please refer your patients to PSC partners in our upcoming new Zoom celebrating diversity in PSC support group. I think that would be a wonderful platform for their engagement. With that, I think we will move it to Ricky. We're over time. Sorry.
Quite all right. Thank you, everybody, for staying. And I just have to say, wow, this was a fantastic beginning conversation for all of us. And a huge thank you to our expert and compassionate moderators and panelists who openly shared your perspectives and your advice on the direction of our future DEI efforts. We really need to focus on solutions, and I'm so happy to hear the many, many impactful suggestions that were generated today. Some repeated themes that I heard were things that PSC Partners needs to start doing is start by learning what's important to these patients from the underserved communities, and then determine the best ways that we can address their concerns and gain their trust by helping patients access and navigate care, help them access health insurance, find expert providers, maybe help in how they get transportation, how patients learn about clinical trials and why it's so important for them to be included. And then the importance of really understanding different cultural perspectives, because that's where a lot of these barriers are coming from. And really creating a safe and welcoming environment. It's all so important, and this has just been fantastic today. So by continuing to work together as multi-stakeholders, I know we can make great progress. Dr. Costello's idea of creating a patient advisory committee was a good one to consider. And as Dr. Yimam mentioned, we have our first Zoom room support group embracing diversity for these communities on January 11th. Everybody is invited and welcome. And our goal going forward is to have DEI permeate throughout our entire organization. And as Joanne mentioned, DI is an important consideration in all our programs, our research grants, natural history study, patient registry, creation of a patient-reported outcomes measure, strategic research plans, support groups, and many other things. So if you would like to become involved, and I hope you will, or you want to share more suggestions, please write to us contact us at pscpartners.org. We are really happy to continue this collaborative effort with input from patients, caregivers, clinicians, researchers, and industry. And to quote the words of DEI expert Arthur Chan, diversity is a fact, inclusion is an action, equity is a choice, and belonging is an outcome. So I'd like to finish by just quickly going over future events. Please visit pscpartners.org. Listen to our monthly podcast. And this month's podcast was with Dr. Yimam. It's a wonderful podcast about DEI. Visit our website for updated COVID information. Sign up for our mailing list if you're not on it. Follow us on social media. Oh, I forgot, join the patient registry. Very important if you're not in it yet. If you're in Canada, we also have pscpartners.ca, the Canadian group. We work together on everything. Post-conference webinars listed here, they will all be rescheduled in early 2023. Zoom rooms are all at 6 to 7 p.m. Mountain Time. So November 30th, spouses, caregivers, and parents. December 6th, those living with loss. And January 11th, celebrating diversity in PSC. So thank you all again. Thank you to our sponsors, and wishing everybody a very happy Thanksgiving holiday. And thank you again for coming tonight and being a part of this. Bye-bye.